Right. A warm welcome to everyone, and thank you for joining us for the third and final installment of our 2024-25 Breathe Change Policy Series. My name is Sam Ball, and I'm the Director of Public Policy and Advocacy with the Lung Health Foundation. Today, we'll be exploring Canada's health system's global ranking in the area of prevention and management of chronic obstructive pulmonary disease, or COPD, as well as highlighting work that can drive meaningful improvement in how we manage COPD in Canada. Before we begin today's panel, the Lung Health Foundation would like to acknowledge its commitment to the recommendations of the Truth and Reconciliation Commission. As an important part of our commitment to reconciliation, we would like to begin by acknowledging that the land on which we stand is the traditional territory of the Anishinaabeg, Mississaugas of the Credit First Nation, the Haudenosaunee, and the Huron-Wendat. This land is now home to many Indigenous nations from across Turtle Island, including the Inuit and the Métis. We acknowledge this land because it's important to remind ourselves that we are working on behalf of all Canadians, including Indigenous people who have been and continue to be negatively impacted by Canada's colonial history. It is impossible to have valuable conversations about lung health in Canada without connecting these conversations to the harms done to Indigenous communities. To this day, Indigenous peoples in Canada face health disparities and poor lung health outcomes. While we continue to learn, the Lung Health Foundation is committed to doing our part in reducing these health disparities and enhancing the healthcare system to meet the needs of Indigenous communities. We recognize that many of you are attending virtually today and are working on parcels of land that do not apply to this land acknowledgement. We invite those of you in Canada to take some time after this meeting to learn about the colonial and treaty history of the land you live and work on, and reflect on the roles we can play to ensure that disparities in health can be successfully eliminated. Through forums like today's session, the Lung Health Foundation continues its leadership role as the voice for Canadians to ensure we all breathe easier. Our policy forums are designed to tackle some of the most urgent and pressing issues facing people living with lung disease and the healthcare system today. The policy forums are pivotal to our foundation's mission work. Each forum provides a strategic opportunity to develop creative and actionable solutions on issues of growing provincial and/or national concern, and brings together thought leaders from the public and private sectors to discuss urgent and emerging issues in health policy. Now, a little bit about COPD. COPD is the name for a group of lung diseases where people have difficulty breathing because their airways become inflamed and narrowed. It's estimated that almost 2 million Canadians live with COPD, and that almost as many have COPD and don't know it. COPD is a public health crisis. 1 in 4 Canadians will develop COPD in their lifetime due to occupational hazards, genetics, smoking, secondhand smoke, or a combination of these factors. The estimated cost of COPD on the Canadian healthcare system is expected to rise to $9.45 billion by 2030. While COPD is progressively debilitating, with early diagnosis and proper management, Canadians living with COPD can continue to have a high quality of life for many years. We are here today to raise awareness and advocate for health policies initiatives that will ensure that this happens. I'd like to take a moment to thank our sponsors for making this panel possible today. Further, the Lung Health Foundation is a registered charity, and as such, we rely on sponsors and donors to support our mission of improving the lung health of Canadians. We focus on investing in research, education, and advocacy that prevent lung disease, help people manage their lung conditions, and promote policy change to create a world where everyone can breathe easier. If you'd like to support our efforts, please consider making a donation using the link in the chat. Please feel free, as we move forward, to put questions and comments or thoughts in the chat, and we'll have a Q&A period after each presentation and a longer one towards the end. Please engage in the chat throughout. One last piece of housekeeping, and then I'll jump into speaker introductions. We've got a few things going on at LHF today, so I'll be co-facilitating this session with Riley Sanders, our Senior Manager of Public Policy and Advocacy, who you'll meet towards the end of today's session. So, on to the presentations. I'll introduce all our speakers first, and then we'll jump right in with Bogie and his team. So joining us today from the Copenhagen Institute for Future Studies are the Director Bogi Eliassen and Vice Director Jo-Max Joachim. Their work dives into topics such as the future of genomics, data, digital functions, and their integration with health. The Copenhagen Institute for Future Studies has developed the COPD index we're going to be learning about today, a unique data tool for assessing both country health systems' approach to preventing and managing COPD, as well as other related factors that may impact COPD severity and control. Bogi and Jo-Max are here with us today to discuss the index and share key insights on Canada's performance in managing COPD. Also joining us today is Dr. Jan-Willem Cox, who is a general practitioner, professor of inhalation medicine at the Observational and Pragmatic Research Institute in Singapore and managing director of the General Practitioners Research Institute. He's the immediate past president of the International Primary Care Respiratory Group. Breathlessness in a Box is an initiative of the YBD Research Foundation, which aims to make state-of-the-art diagnostic tools available to primary care practices all over the world through broad nonprofit research programs. YBD Research Foundation is committed to facilitating global access to breathlessness diagnostics in a box. And Dr. Cox is joining us today to tell us more about this initiative and how it could be implemented in Canada. And our final presenters are Dr. Gracia Mabaya and Dr. Rebecca Adaman, who are leads at Ontario Health, where they have been spearheading and contributing to the development, refinement, and implementation of quality standards. They're joining us today to talk about the recent update of the COPD quality standards and implementation work to improve care in the community for Ontarians living with COPD. Thank you to all our speakers, Bogi, Jo-Max, Jan-Willem, Gracia, and Rebecca for joining us today. Now, it's with great pleasure that I hand it over to Bogi and Jo-Max, who will talk about Canada's ranking on the Global COPD Index.
Thank you so much. And thank you also for this introduction to why this is necessary. And before we go into the slide, I would just like to say also that for us, this is really a question about dignity. And this is also why I really appreciate, and we really appreciate your way of approaching COPD, that it's much more than just thinking about if there is a treatment or not. This is really about how we help people and also how we help a part of the weakest in society. So, very good. As said, I'm Bogi Eliassen. I'm the Director of Health at the Copenhagen Institute for Future Studies, and Jo-Max is our Vice Director, and we have both been heavily involved with the COPD Index. A part of this is really about how do you build trust with data-driven tools, but also how do you use data to improve the situation for COPD and COPD patients in it. Next one, please. So first, a little bit about the Institute. It was established in 1969 by a former health minister and the first OECD General Secretary, Mr. Christensen, who wanted a independent of public and private sector self-governing institutes to be able to both work with foresight, but also really to build bridges between the different parts of society. Next. So just for disclosures, in here we need to be clear on that we have unrestricted support for the development from Sanofi and Regeneron, but we are working and have been working totally independently with the research and the insights and the recommendations within the index. Thank you. So now coming to the index, and first I would just like to say to the audience, if you have any questions, please send them with the chat that you can, and somebody can interrupt me or Jo-Max, and we can take questions along the way if needed. So we know that trust or lack of trust is quite a big challenge in our countries, OECD countries as well. And low trust is also built on that we might not be doing something. And one way of saying this is also, are you trustworthy? Why should anybody trust you if the way you're doing the work is not trustworthy? So the trustworthiness is something to build with and use data and use knowledge to go forward, which is a part of why we work with this and other indices. Next one, please. So you could say that we also want to use evidence really to push trust forward. And if you go to the next one, a part of these are 4 pillars that we really are thinking about. Why is this necessary? So we work primarily with trying to improve health to be more fair, to be based on dignity, to be sustainable. And in that part, we also need evidence and data to help move decisions from emotions to facts, so we actually can base them and help base them on what is reality, and also help prioritizing, so we are solving the most severe problems first. For instance, that COPD is the 3rd biggest killer in the world, but practically has no priority in health systems, is a case of that we are not using data. And with that data, we can begin to support movement for change if we make the data and insights accessible. So it's not just about producing and harvesting data, but how do we make this usable and understandable? And with that, we can begin to build leadership for change, which is also the purpose of this work. Next one. So there are some pillars of the index is to have this credibility. So we have a credibility in what we are putting forward can actually be used. It has to have real impact for the people. So that means the patients now, but hopefully also preventing, so we can reduce the number of patients in the future. It has to be clear and easy to use. And we will come more in on what we are thinking about on that in the end of the presentation. We really want to not just look at data as data points on what is happening where, but also to begin to support best practices and share best practices so we can help each other. And then, as I said in the beginning, equity and sustainability, of course, with the dignity are key here. So next one. And here we could also say that we have we have a huge large and growing burden of COPD. So 300 to 400 million affected worldwide, predicted to 600 million by 2050. It's estimated to be 8.5% of all non-communicable disease-related deaths, which is quite a high number. Third biggest cause of death globally. The cost I can't even mention because it's so high that's expected on this. And yet, 45% of the public don't even know the COPD is a lung disease. So there are many challenges to work with in order to get this forward, which is why we think that this work is very important, and the work that you are doing is extremely important in order to get better understanding and to be able to work better with COPD. But we need to have a broader acknowledgement that there is a challenge before we actually get this forward. Next one, please. And here we can also say that there is a socioeconomic status, so 1.5 to 3 times more prevalent in people with low socioeconomic status. But it's while there are many countries, smoking is the biggest impact in low and middle income countries. Indoor air pollution, especially from cooking, is a huge part of this. And 90% of the deaths of COPD for under 70 years old is in low and middle income countries. So there are some equity questions, equality questions we really need to consider and take responsibility in. Next one, please. And here we can also go into our vision. So as it says here, we envision a world where COPD is effectively prevented and managed through innovative policy, equitable care, global collaboration, and heightened public awareness driven by the insights of the COPD index. So this is really about thinking patients health systems, policy, and society in general in a more holistic way, and how can we then help in many parts, because a lot of the COPD reduction is not in the health system. These are things affected outside the health system that we also need to begin to think more about. Next one, please. And in the index, we have looked at the first 43 countries in the COPD index, and now we are putting the ones that you can see in the bottom right corner. In addition, that we are working for in 25, also to go broader than the OECD countries and a couple of more, in really understanding what is the situation more globally in COPD. And a part of it is comparing, of course, but the important thing is not saying who's number one and who's number two, but really to learn from each other and build a common language on how we can work with improving the situations with COPD by joining forces across countries. And the next one, please. So for the index of COPD that we did last year, this was we had a steering committee of, or still have, of experts, but also experts, patient representatives, meaning doctors and researchers, but also policy experts. For instance, from David Behan, who has a long career in NHS. And also your fellow man, Eric Sutherland, our good friend, who is a senior health economist of OECD, but also whose father died of COPD. So this is not just our work. We really connect with the community and with experts to make sure that this work is relevant and can be used in different ways going forward. The next one, please. The way we have worked with this is to have 5 categories. So as you can see here, policy context, access to care and coverage, health system characteristics, disease burden, and environmental factors, in order to be able to see different parts of the society that are relevant for COPD. When you build an index like this, there will always be opinions on what should be in and what should not be in, and nobody, or you can't make everybody happy with the final decisions that you make on how to work with this. But we had a basis rule when we started. So this is an area where there is an immense need for better knowledge, immense need for better data, for moving forward and helping patients, of building collaboration across countries. So we need to start with something that is much better than what exists, but we know that we have to improve it over time as soon as we get feedback also from people like you who are in this webinar today, which is also why we really like to go out and present and get learnings from you. And as you can see, there are many different parts that are explained or that are looked at in the part, and we can dig a little bit more into that when we show the countries. So with that, I give the floor to Joe Max to take the next on the index findings. I don't know if there are any questions that could also.
We've got a question about a specific valve, so we can come to that one later.
Okay.
There's a question here that says, why has this disease stayed under the radar for so long? I was diagnosed with alpha-1 20 years ago, and really not a lot has changed for treatment. Puffers are not really effective when you cannot breathe. I'm beyond grateful for the treatments and care I've received, and I know I'm very fortunate to live in Canada. Do you have a sense for, I guess the question really is about, do we know why we are where we are?
Yeah. So I can give you some of my personal opinion, and some that we think also can be justified. But of course, there's a difference between countries. In many countries, this has been labeled smoker disease. And there's a huge stigma. And one of the things that we often discuss is how come that the same behavior in some people give lung cancer and some people give COPD. The lung cancer you help, the COPD you don't, or you don't have the, how can I say, the societal compassion in the same way. And this is why it's so important to articulate really look at what this is and how we can work with it and get it known to work with. The other part is that there is a social bias in who gets the disease in general, and it's often also connected with comorbidity. So the people, when they get COPD in a rate where you in other diseases become very desperate for your life, you have very little energy yourself to mobilize in this. Are these fair? How can I say dynamics? No, they're not. But I'm just trying to be honest as I see it in that way. And then it is a very complex disease to diagnose in the beginning. And it's often the last thing that's been looked at when it's fairly late in the stage. So there are some of these things which in principle are avoidable, but which need a huge, how can I say, effort to get right. And exactly that question is also why we're trying to work with this. And then it's not a disease that you die suddenly of in that way. Like you can't identify it like cancer. And on the other hand, you cannot cure people today.
Yeah.
So and that combined is a challenge in my opinion.
Yeah, I agree. Thank you for that. There's no other questions at this time. Joe Max, if you wanted to go ahead.
Thank you, Sam, and thank you, Bogi. As Bogi said, the objective of the index is not to shame countries, but in the ranking that we created. So here we're going to show you a few of the findings of the index, and all the details of the findings you can find actually on the website respiratoryhealth.org, and you can download the report which has all the details. And we'd love to hear from everybody regarding that, because this is just a start and we're hoping to improve. So as you can see on the chart, this is the ranking of the different countries that we already sort of collected data on. We're adding in a number of countries this year. The overall average is only 63.4, so there's room for improvement. But the difference between the best one and the least is 22.6 points. So Canada's scoring 71.5. Australia is the best at 71.5. Canada is the 11th at 65.6, and Denmark is actually the 22nd country at 62.9. And there are a number of reasons for that. Now you can see the differences in the categories as well. The most notable category that we've seen has an impact is obviously the policy category. This is where decisions are made, implementations are forced or rolled out. But in every category there's room for improvement. One of the interesting findings is that only 16 out of the 34 countries had COPD strategies, well-developed, articulated, and communicated COPD strategies that were consistent with what is needed in order to provide the care for COPD. And only in 6 of those countries were there properly implemented and operational strategies. And this is important because having a strategy and the guidelines, I mean, in some of the countries, the experts did not know where the latest strategy was, or the strategy was fragmented amongst different documents. There was sort of the experts did not, different let's say stakeholders did not know where to look for information on the best care and standards of care. So this is very important to make sure that the implementation and making the strategy operational is also looked at more specifically. Some of the interesting findings also include looking at the potential relationships between indicators. So for instance, here it's about looking at the difference between disability-adjusted life years accountable to COPD and public spending. So this is not always a direct relationship. As you'll note later, Canada spends far less than Denmark and still ranked better. So there are different things that can be looked at in order to try to identify where initiatives and where support can be provided. Readmission rates as well. A lot of organizations, countries, and hospitals try to keep the average length of stay in hospitals as low as possible. But that can also, specifically when it comes to COPD cases, increase the readmission rate, which makes actually the condition worse. So these are some of the things that could be improved, or at least what we're trying to say with that is that the experts, or because sometimes when a patient is admitted to a hospital and taken care of for a certain condition, they're in a ward where the respiratory experts may not be. And even though they may be treated for something else, when they're discharged, this causes a decline in their or an exacerbation in their COPD or different respiratory disease. So it's something interesting we identified. Also, tobacco control policies, the robustness of tobacco control policies and the use rates of different tobacco products and nicotine products. There are control policies there. They need to be strengthened in many places. And we are working on the tobacco and nicotine report this year as well to try to identify where more attention is needed. In terms of overall findings, not necessarily specific to Canada, but overall, we see what I mentioned, that the insufficient implementation of the strategies, necessity for doing more when it comes to applying tobacco and nicotine controls, which is one of the major causes of respiratory diseases. Looking at the relationship between the care sectors, so we're looking at primary care versus tertiary care. How is the disease managed across those? How can they actually help each other out more closely? Looking at the societal cost and the impact of that, and where more money should be spent maybe on prevention, the efficiency of the care, the overall improvement in efficiency of the care system, and how data can actually be used to reflect what's actually happening in this space are areas that also need attention. The overall finding, which is something we know, but we still need to figure out how to engage the right stakeholders to do, is figuring out how to create a more coordinated approach and integrated approach to helping individuals who are suffering from these diseases. And here I'll hand over back to Bogi to show some of the data specifically related to Canada.
I do have one question, if I can just jump in. A question about how does the average score compare to other non-communicable diseases like heart failure or diabetes? Do you have any sense of that?
Well, you can't actually compare the scores. I mean, if you check the respiratory.health, health.org website, you'll also notice that 2 years ago we worked also on a severe asthma index, and we've explored trying to compare scores, but because of the different nature of the indicators, the scores aren't really comparable. As we are adding more countries, we're realizing that the scores may not even be comparable when you're looking at different regions of the world, because they may not have the same metrics available, or the same standards of care, or the same way of doing things. So the score is just an indicator. It's more importantly is to look at the content of the different categories and see where there are opportunities to improve.
Great, thank you.
Yes, thank you so much. So I think also going back to that question and And for the summary of things that we actually know that Jean-Max explained. So a part of this is really to say, okay, here we have what is happening, but we need to move from the what to the how. So it's not good enough that we all agree on what is wrong if we can't figure out to do something with it. So that's really rethinking, are we doing the things right? And are we doing the right things, as we normally say with our language? And that has also been our core, for instance, in our Nordic Health 2030 work on how do we actually apply those things that already exists and the knowledge that we have to improve health. Okay. So now just some country overviews with Canada and compared with Australia and Denmark. So next one, please. So when we look at the main takeaways in Canada, so there is a comprehensive COPD strategy, national strategy, and strong guidelines, and relatively high access to care, you can say. What we see are strong tobacco control laws, but need for improvement in maternal smoking rates, and room for improvements in health system characteristics, indicating a need for more integrated care. Of course, and this is also this was the Australian one that is doing well, and we can also see the high score. The death rate is down to 5.4, and tobacco use of adults is just over 13%. And the social cost is also middle, I can say, not really low. And then if we go to Canada, where we can see at that strong tobacco control policy have been a key to reducing the burden of COPD. There's a relatively low number of respiratory specialists and gaps in access to COPD care, but the highest level of universal health service coverage. So the death rate is also low, down to under 5%. The tobacco use is high, but the societal cost per capita is lower than in Australia. And then if we go to Denmark on the next one, so it has the highest burden of COPD and the second highest rate of COPD deaths. It has also a very high smoking rate, as you can see. It has fairly good diagnostic conditions. There's robust care referral pathways and access to telemedicine. But the access to specialist care would improve Denmark's overall score, which is 22. And one thing here is also how you look on the guidelines and strategies, which depending on how you look at it are not present in the Danish case. But also what might have an effect here is that there's a lot of data in Denmark, and that might not be necessarily good when you compare with the rest of the world where you don't have as much data, just to say that those are also things we need to think about when we have an index. So if you go with the next one, please. So as an example, when we look at the policy context and just compare Denmark and Canada, and sorry, I just forgot to mention what Jean-Max also, as we go to the previous one, that the cost per capita, social cost of COPD per capita in Denmark is very high, as you can see, $1,655. So next one, please. So if we compare here, just taking the policy context, you can see that there's a lot of similarity between Canada and Denmark. So, but also some differences. So the personalized COPD care look more or less the same. Tobacco control, Canada's stronger than Denmark. COPD strategy is low on both. Guidelines on best practices is higher in Denmark than in Canada, and occupational exposure is much higher in Denmark than in Canada. Next one, please. And this is also where we can be more granular and looking at different aspects of it, and you can play around with the webpage, the access to coverage. Also, you can see that there are some differences in the patterns. There are some similarities, for instance, on spirometry access, but not on pulmonary reoccupation access, where Denmark is very high and Canada is low. Canada is higher on health services on this part, and also on universal health coverage. So this is also what we could use to estimate and look at, okay, what works, what doesn't work, where is it, but that we should invest in order to improve things if we look at it from a decision maker point of view. Next one, please. And health system characteristics. Here you can see that the hospitalization in Denmark is much lower than in Canada. But when it comes to influenza immunization rates, Canada is a little bit lower, and hospital readmission are much higher in Canada. And on the health data collection and reporting, we actually are on the same level. Next one, please. So, and then disease burden. Tuberculosis is more or less on the same. The cost of COPD that we looked at before, and then we also the prevalence of disease where we can see that Denmark is higher on that part. And if we take the next one, so on the environmental factors, you can see there is a lot of similarity between the countries on most of the parts here. And if we then go back to the global call to actions on the next one, please, you can say that these are the global call to actions, which are not rocket science, they are not new, but old problems do not go away because you find new call to actions. So that's very important also when you do something evidence-based, that you actually stay with the result that is there. So Unite for COPD really to develop an implementation of policies and consist and uniform definition of COPD, which also is a challenge. Prevent, so tobacco control, addressing broader risk factors, and really the barriers to diagnosis. Really to empower and give agencies to COPD patients, so increased support for the organizations, opportunities for self-management and comprehensive support outside of the clinic or clinical setting. And then what we also talked about, really to get a recognition of COPD, so awareness raising, the screening programs, and the right service at the right time, so being much earlier with the diagnosis and the intervention. And then to understand the COPD much better. So, and if you are interested in looking more at our repositories on the COPD Index website of data tool, you can see the hyperlink beneath respiratoryhealth.org, or you can also scan the QR code. So, so I'm trying to look into the page now. How many are looking at it? I'm joking. Yes.
Looking at your web metrics.
Yes. Any questions?
So there's a lively discussion right now around air quality concerns, and a lot of your comments about the negative bias around COPD as a disease area, particularly in its relationship to smoking, in the chat. There are a couple of clinical questions, and I'll just let our audience know there aren't any sort of clinicians in the COPD space on the call today, I don't think. Certainly, if you have specific questions, please reach out to LHF and we'll make sure to connect you to clinicians who can provide you answers to those questions. But I don't think I'm missing anything, but not at this time. But if you're okay to stay on until the end, we'll have more opportunity for questions.
Yes. Okay.
Great. Well, thank you so
good.
much. This has been really interesting, and I know that
No. I just have we just have some additional points, which is
my apologies. Go ahead.
Which is the brutal future that we can make bright. So now the next phase that we are working with is actually to try to make our indices much easier to use. And here in a Danish setting, there is quite a structured approach to data. So yeah, So you can get access to the data health authorities, data health data authorities, the national statistics. We work with universities, but also with the Lung Association and the Society for Lung Medicine, but also really to build with data, international data, meta-analysis, and different research. So in Denmark right now, there's a work on a health reform. And where COPD is going to be the piloting on NCDs, really to move to as early as possible interventions and diagnosis. So for many years there have been built a lot of programs or guidelines for how to work with COPD. So this is just an example of that. They are very granular on what you should do on rehabilitation, on stop smoking, smoke cessation, physical training, specific health literacy training on COPD, nutritional advice, train how to manage your daily routines with COPD, and many others also, that they have teams that you can come on to train to build networks. And if you can go to the next one. And then we have the programs in that way, but there is also a lot of guidelines on how to treat, how to diagnose, to get rehabilitation in. So there is quite some information in different fora, but still where this often should be caught with the GPs, that is still a bottleneck that we have, or wider in the society in it. So next one, please. And that leads us to Joe Max, who will explain more about our futuristic approach, how we are moving this index forward. Joe Max?
Thank you, Boogie. So as Boogie shared, there's a lot of material out there. And as I mentioned earlier, there's a lot of, not all the material is known or accessible or usable to different stakeholders. So one of the things we're trying to do to take things to the next level is we're working with a medical doctor and AI expert from the University of Southern Denmark on trying to build chatbots that can be used by different stakeholders to get access to discuss COPD related issues with these documents. So essentially, what is happening is that all the documents that Boogie showed are loaded into an AI, a locally based AI, not the ones that we see in the public. So it's a specially built AI where the data is vectorized into a database, and then chatbots are created in order to have a discussion with those documents. So you could ask about the different guidelines, you could ask about opportunities for improvement. At the moment, we're looking at a national chatbot, so one national chatbot per country, to make sure that individuals in that country can look at all the information or query or ask questions with the locally available documents. And we're hoping, if this works out, that we could also integrate them together so that you could actually ask, okay, what can I do compared to this other country? The way we have the charts set up. The idea is to make all of these more accessible, more usable, and in order to facilitate not just access to the standards, but to care. And these chatbots are specifically designed using this retrieval augmented generation approach, so that it doesn't include any biases or creative thinking by the usual chatbots that we see, like ChatGPT and others. These will only provide information that is in the documents and sort of credible information. And so this is what we're trying to do. We're trying to essentially make all this information more accessible and more usable at the national level. And back to you, Bogie.
Yes, thank you so much. And one of the big targets this year is the fourth high-level meeting on United Nations on NCDs, where we are working with the building coalition on really getting respiratory health and COPD on the agenda. It's not really present or very limitedly present in the current NCD resolutions. And this is one of the targets that we see in order to have a document, international document, global document, where you as organizations, where the experts in the country also can go in and argument and educate for that we really need to focus more on COPD, and look, there is actually a global resolution that says so. So that is really also where we ask for collaboration, networking. Let's push this together. This is a coalition effort, and really to bring those things that we have mentioned that should not be so on the table and try to solve them piece by piece. So and with that, I think we say thank you from our side, and I think on the next slide we probably have a link, or the link is also here, so that should be fine. Yeah. And any questions?
We have one question. Do you think you can attribute the increased readmission rates in Canada to the performance in diagnosis and referral pathways? Can you comment on that?
Yeah. So I will let John Max also come in. So Canada is one of these countries which are not easy to work with, because it is a federative approach in it. Yeah, you can laugh. We didn't when we had to figure this out.
It's okay. We know what we're strong at. We know what we're not good at.
So probably one of the things that is important in Canada is also not just to do one size fits all. But readmission is also so. What is quite clear, what reduces the readmission in Denmark is to try to keep people at home, for instance, with telemedicine approaches and different kinds. So you can see quite fast if when they get stressed and think that something is on the way, that they actually can see that this is okay. You don't need to go in. So there are probably many ways, and we know that from many countries you get a big run on the emergency because there is nowhere else to go. So those are also structural parts in the health system. I don't know, John Max, if you have a special observation on Canada in this one.
Not specifically. We can certainly look into it, but we, as mentioned before, we see that there is a relationship between in different countries, and so I mean, we can certainly try to look into it further for you, and then get back to you.
Something we've been thinking about here at the Lung Health Foundation is, so healthcare is delivered at the provincial level here. So there's 13 jurisdictions with a federal overarching. Was that a unique challenge or a challenge in terms of understanding the data as you worked through the indices?
Absolutely. I mean, access to data and the availability of data is critical. We're just scratching the surface. This is like the first iteration, as Bogie mentioned, and this is not something that we can do alone without everybody's help. So we are looking to expand this effort and get more collaboration and feedback in order to improve it. This is something that we did for everybody. This is not something that it's open to the public, open for the benefit of all.
Great. Well, I've really thoroughly enjoyed this presentation. Thank you so much. There's just a quote, and there's a big long. Anyways, we can come back to that. We'll move along. So thank you both so much. And we will move on to our next presenters. Let me find my script here. Get back on track. Okay. Lovely discussion in our chat. So thank you for encouraging that. So now, next up, I'm pleased to pass it over to Dr. Jan Wilhelm Cox, who will tell us more about the Breathlessness Diagnostics in a Box initiative and how it could be implemented in Canada. Well, welcome, Jan.
Yeah, thank you so much. I'd like to thank the Lung Health Foundation really for inviting me to share this, and also the Dr. Alec Kaplan, a good friend of mine, a family doctor, to tell you about this initiative. So, and I'm really pleased to share this with you. I'm trying to share my presentation, including the voice and the audio, which and the video, which was working when we trialed it, and now I don't have the options.
Oh no!
So maybe somebody can see if
yeah,
I'm
a few
able
slides
to.
In. Did you want to get started, and I'll see if we can get our tech folks on the other end. If nothing, we can queue it up to show it on from ours.
Yeah. So, I'm professor of inhalation medicine. I'm a family doctor or general practitioner in the Netherlands, and actually, this Breathless Diagnostics in a Box is an initiative that we developed as a research institute and as a general practitioner to think, okay, we should do better in this for everybody with breathlessness, not only COPD, but all cause of breathlessness. And what we see is that a lot of people, about 10% of the adult population, have breathlessness, and it's really one of the common reasons for people to go to the primary care or the family doctor, and but not all the tests. And we've just heard Bobby talk about the late diagnosis and the challenges to get a diagnosis. It's not always efficient, and the pathways are not always clear. There have been some breathlessness pathways developed, and they're often based in hospitals where then cardiologists and pulmonologists work together, but they're reasonably small. The waiting time is still quite a bit, and actually, as a primary care physician, I thought, well, this is not the way to go, because I think within primary care, close to the people, we should have a way to get all the diagnostics done quickly. And that's why we set out to create an easy and reliable diagnostic tool with tools brought together, and not only giving people access to a test, but actually helping my fellow colleagues to provide decision support, so to understand the implications of the different tests. And this is actually part from a broader research projects we've done. And over the last 6 years, we've tried to research and develop tools that work for primary care. And we've developed tools that are really focused on finding people that have symptoms but not yet have a diagnosis. Then, and I'll talk more about the diagnosis part and the collaboration between specialist care and remote support. Then there are people that have a diagnosis, but still experience a lot of symptoms and flare-ups and exacerbations. So we developed algorithms to look into the EMR to find these people that are high risk for future exacerbations, flare-ups, and identify them and present these to the healthcare providers, so they could put their time on those which have most needs. And then when we have a diagnosis and then still having the best management possible is often a challenge. And what we've developed is our websites. It's our medical devices. So it's properly developed with groups of experts, including guideline writers, to have a software that runs primary care physicians or nurses or pharmacists through the right questions to ask, and then based on the most recent international guidelines, actually get individualized the treatment suggestions. And we just finished in the Netherlands an implementation study for the COPD. And what we see there is that 1/3 is managed according to according to guidelines, but still 2/3 of the patients could have optimization in their, for example, pharmacological management. And then I think we do quite well in the Netherlands, but you see that our primary care guideline is about 6 years old, while the guidelines and the knowledge has been updated, and we've updated that in our software. So with this whole suite, we can actually help like a whole approach from finding patients that are symptomatic towards what's the most beneficial care for this individual patient using the optimizers. But I'd like to go more into detail on this yellow box, this breathlessness diagnostics in a box, because breathlessness is a symptom which can be caused by different causes, and of course we're now in this COPD webinar, and COPD is a major cause for breathlessness. About 20% of the people over the age of 40 that come to the primary care physician, the cause is an obstructive lung disease. Another bit smaller proportion is actually a cardiological disease. And about 10% it's caused by anxiety and or depression. And what we wanted to do is not only to have one test, but test all these different causes, because that would prevent people to, for example, with breathlessness, go to a cardiologist, where a cardiologist finds, for example, heart failure, and then the thinking might stop. But what we know is that a lot of people, about 30% of the people with heart failure actually have COPD, and with COPD also have heart failure. So there is a big overlap. So what we wanted to do is create tools that have tools that are available and bring those together. So for the lung part, we use a device which does both spirometry, and you're probably very aware of spirometry, like the forced maneuver, but also oscillometry. And the oscillometry, I'll have a video on that, is a way to test the lungs, but it's instead of a lot of training from both the person who helps the patient to perform the spirometry well, but also the patient that has to really put a lot of effort to get a good test. Oscillometry requires like breathing in and out for 15 seconds, and then with sound, a measurement is done. Do that 3 times, and that's then your measurement. Then we do a laboratory test, but not a test that you have to go somewhere else to go to a laboratory. It's actually this device down here, where it is a portable lab test where you put with a finger prick of blood, like you do with sugar measurement. You do that in this machine, and then it measures the NT-proBNP, which is an important measurement to identify heart failure. So if the heart is in trouble, this will help to identify that. Also, people with pulmonary embolisms get breathlessness, and this is a test, the D-dimer, which can be done on this device as well. Then saturation measurement, and also an ECG. And this is this small box down there. it is actually 4 different patches that can be put on the chest, and it will lead to a full 12-lead ECG. And this device is used, for example, in international flights of Lufthansa, from the airline, and flight attendants can use this in emergency situations. So it's very easy to apply. Then the interpretation, to be honest, I've tried many times to do these courses on ECG reading. I can find the highlights, but actually we now send this to an AI algorithm and get the interpretation. We have an iPad that leads the healthcare provider, which could be a doctor, could be a nurse, could be a practice assistant. So you don't need a lot of training to do all these tests through all the steps, and all the information goes into this iPad, and we have our algorithms that have been set up with an international group of experts and based on all the different guidelines to create a patient report saying, well, this patient actually probably has COPD, also with the ECG and NT-proBNP, heart failure is also likely. So if needed, do extra tests to confirm the diagnosis, like an ultrasound of the heart, and start treatment. So this is really like a box with all the devices in that can be taken to like elderly homes. It could be taken into more remote areas. As long as there is an internet connection, everything can work. It's all battery powered as well. So that's really a project we've done to help primary care to do this. We did a pilot in 122 patients in Dutch general practices. We got feedback on how this was used. We've updated this based on the pilot study. We first had a different NT-proBNP test. We now have this more sophisticated lab test. We also have the anxiety and depression questionnaire in there. And we are currently doing a study in 900 patients in Spain, the Netherlands, and Portugal to see if it really reduces the time to first diagnosis and increases the amount of diagnosis because we know we're missing quite some COPD, for example, in patients with cardiovascular disease. And this shows from this pilot, and I think I'd like to highlight here, so with the people that had not had any prior diagnosis of asthma or COPD, but came to the nurse because of cardiovascular annual checkups, we did the test, and about 30% of these people that came to the nurse for their heart, not for their lungs, actually had obstructive lung disease. So I want to show you the video, and I'm gonna stop sharing and try to share again and see if that already works. No, it doesn't. So maybe somebody else can show the video who's allowed to share that. Is that working? And it's just 40 seconds video, but it shows you how this other lung test is being done. Maybe in Canada that there is a much more knowledge about oscillometry than elsewhere, but this is how this is done. Okay, I see there is no audio there, but what I tell him, just breathe in and out just quietly as you would normally do. And then he breathed in for 15 seconds. I see the video is just not yeah. So this is already, so this is doing the measurement. You see him breathe. And what's important is that for quality, you do this 3 times. And you see, this is the whole test. And what this will deliver is a report for the clinicians. And in that report, it's you can actually see. Yeah, just continue. I'll just talk what I say then. Yeah, you got all the numbers. What is needed, but you also see an interpretation of the results, including an image of lungs that actually helps to interpret the results, because the technique is already existing for like 40 years, but only now it gets more affordable to have these devices, and also the interpretation is much easier to do. So from this oscillometry picture, you see that this is the result from the entire box. So this, for the lung function test in this patient from the study, you see that there is obstruction, there's an abnormal lung function. There was a high score on depression, normal D-dimer test, which is the test for pulmonary embolism, and the ECG was normal. So in this report, for this patient, all the results came together, where they said, well, the breathlessness could be partly explained by obstructive lung disease, pulmonary embolism is unlikely, and heart failure is also unlikely. So this is, and indicates for possible depression. It shows further advice, and because this is the study still, we ask if patients get referred, the clinicians can scan the QR and add data for this patient. So this is really helping to speed up the diagnostic pathway for breathlessness. So we've done a pilot. We're now doing the randomized control trial, high scientific standards, step wedge, difficult thing to do in these countries, but actually to show its effectiveness. While I've been talking about this and developing this, a lot of people ask, well, can we start using it? And also in Canada, I've talked to several pulmonologists and family doctors, and they ask, well, is there any way we could work with this? And when we started the applied for ethical committee in Spain, actually the feedback from the ethical committee was, well, it's nice that you want to show effectiveness, but this is a no-brainer because you bring everything together. So this will be faster for a diagnosis, but still we do that study. But at the same time, we've developed this BEOP Empower project where we say, well, let's not only do this randomized, but help these boxes with our research foundation, a not-for-profit research foundation, to get these boxes into clinical practice, and also do it in different health systems to really learn what's the best use case. Because one of the pulmonologists in Canada said, well, I think I'm also responsible for this elderly care home. I'd like to take this box there, for example. So what we propose is to find people, systems that want to be part of this larger worldwide observational outcome study, where we provide the box, and people will then after 3 and 6 months do a questionnaire to find out what diagnoses were made, how did they perceive it, but actually start using this and collecting data on the fly, because all the different tests are available. What we do is bring them together and help with the interpretation. So that's one of the things I've been working on for the last like 2-3 years, and So I was really enthusiastic when I got this invitation, because I think Canada would be a perfect country to for example, to implement this, and especially because of, well, the innovation that is in Canada there. So to see how this could help. If you have any other questions, please contact me or send an email to the Yellow Box Foundation, and I'm happy to take any questions now.
Thanks, Dan William. I'm taking over for Sam. I'm Riley Sanders. She just stepped away. I did see a question in the chat, and I think you sort of already spoke to it a little bit, but what can we do to help implement this? Or we have a lot of healthcare professionals and primary care physicians on the call right now. What is the next step, or how can we get involved? And there's even questions about, is it possible to purchase this box themselves or anything like that privately?
Yeah. So there is a lot of regulation around these algorithms, which makes it a medical device, which we plan to do in Europe, like within this summer. But if you we set this off as a very light touch protocol, as a research protocol, and if anybody in Canada wants to submit this protocol, which we have available, to their ethics committee and be part of this movement, then happy to do so. We set up this infrastructure, research infrastructure. We got like the research infrastructure for free, because we're a not-for-profit organization, and so the real costs are in the cost of the devices. The box, all the devices in there, is about €7,500, and then you've got this lung test, ECG, all these different tests, and per patient to do all the tests, all the disposables, is around €30 per whole test. I don't have the money to give these boxes away, but I do have the possibility that if there's anybody who wants to partly fund a government or individuals, and we do this as a project, well, you can start like within 2 months, and we've got it running in Canada. So I think that yes, please contact me to be part of this.
Great, thank you. And actually, if you look in the chat, there's the website there has a link, and there's a take action button that you can click onto to get in contact as well. So if you have any questions, or if you want to get involved, there's also some notes in here, for example, that this might be a great option for our primary care sites that work in respiratory health here in Ontario. So we'll definitely follow up on that. And if anyone wants to get in contact, the chat has the link in it as well. Okay, I'm just seeing if there's any more questions I missed. I think that might be it. Thank you, Dr. Cox, and I would like to welcome Dr. Mabaya and Dr. Adaman right now to take over this presentation and speak a little bit about the work that they're doing here in Ontario.
Thank you so much, Riley. Good afternoon, everyone. It's a pleasure for us to be here. I'm just going to share my slides. And I believe, Rebecca, can you give me a thumbs up if it's showing well? Awesome. Thank you so much. Thank you so much to the Lung Health Foundation team for allowing us to present this afternoon on this really important work, and really echoing what the presenters shared earlier on really the importance of this work for improving patient care and experience, as well as their outcomes. And I'm also delighted to present with my colleague, Rebecca. So we'll be going through this presentation, really highlighting, so I have things popping up on my screen. We'll be highlighting the Ontario Health COPD quality standard, and we'll also be focusing on highlighting key areas for improving care for people with COPD, and we'll describe Ontario Health's quality standard implementation approach, as well as highlight some implementation initiatives and support for the COPD quality standard specifically. So the development of quality standards has roots within Health Quality Ontario's previous mandate, which was under the Excellent Care for All Act, and is reflected in the more recent 2019 Connecting Care Act, in which Ontario Health's legislative mandate is contained. So more powerful than policy, and what really drives our work is the goal of addressing variation and gaps between what we know is evidence-based or optimal care and the care being delivered in the province of Ontario. And we do this by developing tools and resources to really guide system and care improvements in order to address these gaps and inconsistencies. And so quality standards are meant to inform clinicians and patients of what high quality care looks like, and by including a small set of high impact statements. And they're grounded in the best available evidence, driven by data. They're patient-centered and equity-focused. And so to date, we have about 40 quality standards that are available in our library. And so our program, reaching its mature state, has now focused a lot of attention on really implementation work, as well as really demonstrating the impact of quality standards. So in October 2023, we released a 5-year update of the COPD quality standard. And the scope of this quality standard is really to address care for people with COPD, including the assessment of people who may have COPD, and really providing guidance on the diagnosis, management, and treatment of COPD in community-based settings. And so the advisory committee that was convened to develop this quality standard identified 14 key areas for improving care for people with COPD in Ontario. And for each of these topic areas, there's a specific quality statement, as well as associated definitions for the content of the quality statement. And a focus for this 5-year update was really on addressing risk correction. And so what we know is that the practice of risk correction has a long history, and addressing it, the inappropriate use of race within clinical algorithms, has really become a priority, not just within Ontario, but in Canada, the US, as well as in Europe. And this practice really raises concerns because it is not really grounded in scientific evidence and is often silently embedded within clinical guidelines and algorithms. And it's based on false and racist myths that are really harmful to patients from racialized groups. So we made the change within the COPD quality standard in alignment with our the COPD E2P tool, content on spirometry, and Rebecca will speak more specifically on the E2P tool. And so this change was made based on the recent American Thoracic Society consensus statement on race-neutral interpretation of spirometry. So as a result of the 5-year update, there were many changes that were made to the COPD quality standard. And you can find a summary of this on pages 7 and 8 of the quality standard. But with respect to pulmonary function testing using spirometry, we updated the definitions of spirometry, as well as airflow limitations in quality statement 1 and quality statement 2. And this was done to align with the American Thoracic Society consensus statement. So the content of the two definitions in the statements were updated to really highlight the fact that lung function has recently been associated with factors beyond the complex combination of social, cultural, and genetic factors that are often ascribed to race and ethnicity, such as socioeconomic status and education. So the quality standard calls for the use of a race and ethnicity neutral approach to interpreting and reporting spirometry using average reference equations, such as the Global Lung Health Initiative, or GLI average equation, which really promotes health equity and really ensures that patients from racialized groups are not negatively affected. So to support these changes, I mentioned already the ATS consensus statement. In Canada, the Canadian Thoracic Society does not yet have a consensus statement, but they collaborated with the American Thoracic Society on research recommendations, highlighting the need for research to really address the fact that past perceptions and practices around the interpretation of pulmonary function testing results are supported by limited scientific evidence and measures that really lack reliability. And we've also come across other peer-reviewed publications that have concluded that risk correction in pulmonary function testing is really a standard clinical practice that lacks a biological basis. And recent studies conducted, particularly within the United States, highlighted that removing risk correction in pulmonary function testing led to a significant increase in the diagnosed prevalence and severity of pulmonary disease, particularly among Black patients. So now I'll dive into our implementation approach at a higher level. So the Clinical and Quality Standards Program at Ontario Health has really evolved through the inception of the Evidence to Practice program, which Rebecca will speak to in a bit. And the program has also evolved through the advancement of equity, as well as providing timely and actionable data via quarterly e-reports that the regions have access to. The program also has an implementation approach that aligns with the Ontario Health Integrated Quality Framework and is really guided by data and evidence and includes 2 strategic objectives to embed quality in Ontario Health priority initiatives and really drive and foster system improvements. And the implementation approach highlights 4 key functions which align with the domains of healthcare quality. These are understanding quality gaps, synthesizing evidence, engaging patients and providers and the health system, and accelerating change. So now we'll dive into our specific implementation initiatives and support. So the first one I want to highlight is with respect to the use of a race-neutral approach for interpreting spirometry. We developed information documents for clinicians and patients on the updated content within the COPD quality standard. And these are available on our website. And if you just scan the QR code, you may access them and really provide more information about the changes that were made and the context and applicability to practice within Ontario. So now I'll speak about our COPD implementation toolkit, and I'll do a little demo of the toolkit. So over the past year, the Lung Health Foundation and Ontario Health partnered to really build a digital and interactive COPD toolkit. And so this toolkit is created for clinicians, health organizations, health system planners to readily adopt the COPD quality standard, as well as the 14 quality statements that are embedded within it. And if you scan the QR code, you will be guided to the Lung Health Foundation website. But when I do the demo, I'll go through the Health Quality Ontario Health website to show how you can access the toolkit. And so the toolkit includes a wide array of tools and resources that support the implementation of high quality and evidence-based COPD care across the entire disease spectrum. So really looking from early diagnosis to end-of-life care. And unlike other toolkits, it really consists not only of evidence-based tools and resources for both patients and clinicians, but also key implementation support such as EMR integratable forms. There are also digital decision aid tools, regional portals and databases, and digital health system platforms, and much more. And so really the goal through this toolkit is to provide solutions to implementation barriers and improve clinician workflows, to be able to support the use of evidence-based guidelines in care and ultimately enhance patient care and reduce healthcare utilization. So the toolkit was recently launched at the Lung Health Foundation's Better Breathing Week in January. And so now I will go through a live demonstration of the toolkit. I'm gonna maybe stop sharing my screen. Oh, sorry, end the slideshow here. That way I can put up the website. So I'm not sure if someone in the chat has supported it because I can't see the chat right now, so I'm sharing, has put in the Ontario Health COPD Quality Standard webpage. But if you go to the webpage here, you can see the quality standard is there. There's a patient guide, and then the race neutral supporting documents that I highlighted earlier that you can access for clinicians and patients. There's a placemat that really highlights the quality standard and is meant for clinicians to use within the clinical setting. And then there's a getting started guide with it, which is an implementation resource, but the toolkit is right here. I also wanted to show that the toolkit is available in French, only in PDF format. So in the French, it's right here. You can see the translation, but we'll go to the English version, which will guide us to the Lung Health Foundation website. So if I click here, so then you can see that right under, oops, sorry, I'm just bringing this over. So right here, when you're on the landing page, you can see that the title, underneath the title with a short description of the toolkit, you'll see that there's a search bar here that you can type anything. So as I'm speaking about spirometry, I can type spirometry and I can see tools appear, but I'll go here. So if you scroll, then you'll see the 14 quality statements within there. And so this highlights a care pathway actually that was developed to be interactive. And so you're able to click on any quality statement. And so if I click on diagnosis confirmed with spirometry, You can see here that there are resources underneath the different change ideas. And so if I click on the first change idea, you're able to see the different resources, and the icon tells you whether it is a clinician resource or it is a patient resource. And what you're also able to do is you can share this either with your colleagues or with patients if it's a patient resource by copying the link, or you can just copy the link for your own personal reference. But there's also a very interesting and cool feature where you can save tools and resources to your toolbox. If I click on the star right here and I go above, then I can see that my toolbox has something in here. And that's really cool. And so additionally, there are also different pages here to give you information about the quality standard itself. There is a methodology section that highlights the process for development, as well as the working group that worked on the development of this toolkit. There are health system resources that can be also accessed, as well as the patient resources, just all in a single page here. And so we really encourage you to share this with your networks, with your family members, and you can do so just by clicking here on the different platform that you want to share, via which you want to share the toolkit. So now I will reshare my slides to pass it over to my colleague, Rebecca.
Thanks, Gracia. As you get these up, I'll just say quickly that I'll go through this rather quick so we can get this done before the end and hopefully take some questions if the audience has any. So I'm going to focus on the evidence to practice program, or E2P, which Gracia alluded to earlier as an implementation arm of the COPD quality standard and other quality standards in Ontario. I do want to highlight, to start off, that there are many people who use the E2P tools outside of Ontario. So certainly if you're not in Ontario, you're more than welcome to onboard to these if you think they're relevant to you. So the E2P program's mission is to translate the quality standards directly into clinical decision support tools that are at the point of care. So right now we work in primary care EMRs and acute care HISs, but for the purposes of this presentation, I'll focus on primary care since that's the tool that we currently have available for COPD. Basically our aim or our logic here is that if we implement the quality standards into practice, enable clinicians to practice according to best practice, then we'll have, impact in terms of patient outcomes, patient experience, and we think we'll also have higher data quality as a, data foundation that we need. You can go to the next slide, please, Gracia. So this is what we mean when we say we are embedding the quality standards in practice. So here you can see the COPD quality standard. This is a visual of the primary care encounter with a patient. And you can see that during the visit, you'd go through things such as interview and assessment, treatment plans, patient education, and you can see how it's those different quality statements align there, similar to that pathway that we saw earlier that Gracia popped up. Next slide, please. So this is what the E2P tool looks like in TELUS right now. So one of the EMRs that's really common in Ontario. You can see along the top, there's a toolbar with all the different E2P tools that are currently available, of which COPD is one. If you click on the top COPD button, what will open up is that image on the right as your first kind of view of the tool. So it brings you straight to diagnosis. But there are all those other components as well that I mentioned in that previous slide around treatment, patient education, assessment, all these things. Yeah, thank you. So I just wanted to highlight what the trajectory of the COPD tool in E2P has been. So it's only been in practice for about a year, launched this time last year. You can see that since that time, we've had almost 1,600 clinicians with access, and those clinicians are composed of family physicians, nurse practitioners, and a wide variety of allied health professionals. And I've highlighted here that right now, the COPD E2P tool is only available in TELUS, Accuro, and Oscar. Those are the three main EMRs in Ontario, but certainly we're open to expansion. And then, we've only had this for a year, so it's still early days in terms of implementation. Early to get impact, so we don't have impact data yet in terms of quintuple aim impacts, although we do expect those per my earlier explanation of the mission and vision of E2P. But we do know that the COPD tool does enhance adherence to the quality standards. So for example, to spirometry testing, as you know, as Gracia was talking about, and others on this education session today. So we are excited to see down the road what those impacts look like. Next slide. Finally, I just want to highlight that, you know, we've reached this current state that I just described in E2P, but we are looking towards continuing to evolve the tool. We know that we want to integrate some more advanced technologies to it, such as, you know, many of those that were highlighted today by others and what they're doing in other countries and jurisdictions. These are things we're looking towards as well. So keep your eyes peeled as we, you know, continue to make updates and bring in those advancements to have even more functionalities that will bring positive impacts to clinicians, patients, and the healthcare system as a whole. And as we move then towards really expanding the E2P tool and sustaining the program. So that concludes my quick presentation on E2P there. Just some information here if you want to follow up with myself or Gracia, you can always reach out at the email address here. And I know we don't have too much time for questions at the moment, but I'll pass it over to, I don't know who's going to be doing the discussion. Riley, still on?
Yeah. Thank you so much, Rebecca and Gracia. I don't see any questions in the chat right now, and I know we're almost at time. If anyone has, we maybe have time for 1 or 2 more questions, and then we'll maybe close it off. I don't see any. So I just want to thank you all for your presentation today. And I also just want to talk as well about what it is that we're doing today. Obviously here in Ontario, what we need to do to sort of address this gap and how COPD is remaining to be overlooked and underfunded, we need to get more people involved. We need to raise awareness. We need to advocate for solutions like what's been discussed today. And most importantly, we need to make sure that decision makers start to prioritize lung health. So if you're joining from Ontario today, the Lung Health Foundation would like to urge you to prepare for today's election by reading about our party's platforms, urging your candidates to get breathing on the ballot, and most importantly, going and vote if you haven't already. So to help you with this, we have prepared a platform guide which brings out and highlights each of the parties' healthcare promises that they've laid out for this election. As well, we published an opinion article to raise awareness about lung health and this election too. And you can find the link to all these resources in the chat, as well as an ability to send an email to each of the candidates in your riding saying that you're going to be voting for the candidate who prioritizes lung health. If you're not in Ontario, please continue to watch our social media, sign up for our networks, because we're going to be preparing to do something similar for the federal election later this year. Thank you so much for joining us today, and I wish you all a wonderful rest of your day, and have a great afternoon, and hopefully you guys all are able to make it out to vote even in the snow and bad weather.